believe so.
Well, good afternoon and welcome to the Substance Abuse and Mental Health Service Administration's sponsored webinar, Striving and Thriving Among Certified Peer Specialists. My name is Michael Askew, and I am the Deputy Director of the Office of Recovery and a person with lived experience. Before I introduce our first speaker, I'd like to share about the Office of Recovery. The office was established to advance recovery across the nation. The office will forge partnerships to support all people, families, and communities impacted by mental health and or substance use condition to pursue recovery, build resilience, and achieve wellness. The SAMHSA National Recovery Agenda for the Office of Recovery is 5 goals: inclusion, to foster the meaningful involvement of an array of people with lived or living experience, to improve behavioral health practice and policy to foster the social inclusion of people with behavioral health conditions. Equity, to increase equity and opportunities for recovery for underserved and under-resourced populations and communities including people of color, youth, older adults, women and girls, LGBTQ+, rural, veterans, and people with disabilities. Our third goal is peer services, which we'll talk a little bit more about in this webinar. But it's really to expand peer-provided recovery support services within every community in every part of the world. Social determinants, to address key social determinants that support recovery, including access to high quality and affordable housing, education, social supports, transportation, and employment. And finally, wellness, to expand holistic self-care strategies and to integrate recovery-oriented practices and systemic reform into the full continuing prevention, harm reduction, treatment, crisis care, and recovery support. Today, our presentation is about peer support, which has had significant success in the collaboration within the clinical, treatment, and criminal justice systems, as well as mental health and substance use recovery spaces and other places. I'd like to introduce our first speaker who will provide welcome remarks. Ms. Donna Dimitrovic is the Senior Advisor to the Office of Recovery. Donna?
Thank you, Michael. Good afternoon, everybody. It really is exciting for me to be here with you all today and welcome you to the webinar. I think we're going to get great information and it's going to be quite a good learning experience for all of us. I just wanted to have a couple remarks about peer support and just to talk about how integral it has been in my own journey of recovery, especially in those early years when I needed help navigating an unknown system of care. And it was in particular helpful for me on finding employment opportunities and then really to further my education. So as Michael noted, the Office of Recovery has identified the expansion of peer support as one of our major goals in the Office of Recovery. And over the last 15 years, SAMHSA has been at the forefront of advancing peer support across the continuum of care. Peer support workers can assist a person in or seeking recovery and promote connection and inspire hope across the system. There's a level of acceptance, understanding, and validation that may not be found in other relationships that we have in recovery. Peer supporters really help people develop their own goals, create strategies for progress, and help build steps towards a fulfilling, self-determined life of their choosing. Most importantly, in my opinion, peer support provides that hope that people can and do recover while also helping to break down barriers experienced in finding one's own recovery path without judgment, expectation, rules, or requirements. It's also important for us as individuals with lived experience working in this field to take care of ourselves too along this whole journey. So just wanted to share with you SAMHSA, with help from many of you and experts across the country, has several publications that are available on our website. We recently published the National Model Standards for Peer Support. It was a goal of President Biden's 2022 Unity Agenda. And these standards are designed to accelerate universal adoption, recognition, and integration of the peer workforce, and also to strengthen the foundation which was set by the peer workforce reinforced by SAMHSA's core competencies and implemented by state, local, tribal partners. Our tip 64, incorporating peer support into substance use disorder treatment services, supports learning for the use of peer support services for providers, supervisors, and administrators in substance use disorder treatment programs. We've also developed an advisory, peer support services and crisis care, which outlines the vital component of peer workers within crisis care. These are just a few of the examples I wanted to offer to you of how SAMHSA and the Office of Recovery is involved in expanding peers and peer-provided services within every community. You can find all of these publications on our website. And if you're interested, certainly you can also reach out to any of us. And as we move forward into our second year of the Office of Recovery, we will continue our goal of recognizing and expanding peer support so that every community across the country has the ability to offer to anyone seeking that support. So thanks so much for joining this webinar today. We really appreciate you being here with us. And with that, I'm going to turn it back to our Deputy Director, Michael Askew. Michael?
Well, thank you, Donna. Thank you so much. And so as you continually look in the chat, you will find resources and information. And more importantly, there is a webinar that the Office of Recovery will be providing December the 7th. And feel free to register. It's more of our recovery exchange where we open up dialogue with the recovering community. So feel free to be a part of that. But here at SAMHSA, we are excited in having you join Dr. Laysha Ostrow, the CEO of Live and Learn Incorporated, a California-based social enterprise that connects lived experience with learned expertise in mental health services research. Dr. Ostrow research agenda focuses on employment outcomes and working conditions for individuals with psychiatric histories. She is the principal investigator on the National Institute of Disability, Independent Living, and Rehabilitation Research, funded certified peer specialist career outcome study, and the co-creator of Reclaiming Employment, which supports entrepreneurship by people with mental health challenges around work. Dr. Ostrow holds a Ph.D. from the Johns Hopkins School of Public Health and a Master of Public Policy from Brandeis University. Her lived experience of the special education, Social Security disability, family court, and psychiatric systems informs her research. Today, she will discuss some of the results from the Certified Peer Specialist Career Outcomes Study, a 3-year effort to document the career outcomes of certified peer specialists. Dr. Ostrow will present some of the findings around wages and financial well-being, the workplace burnout, and certified peer specialists in rural communities. The presentation will conclude with lessons learned and suggestions for future research and policy changes to support the peer workforce. Without further ado, let's welcome Dr. Laysha Ostrow.
Hi, I'm Laysha Ostrow. I'm a middle-aged white woman with dark brown hair about to my shoulders. I'm wearing a green shirt and I am in my office. And now we'll be able to share my slides. The title of my presentation is Striving and Thriving Among Certified Peer Specialists, because as Donna pointed out, supporting the workforce that supports recovery is supporting recovery. So I wanted to thank SAMHSA for having us here today, and as well as NIDLR, who funded this study, and just to say that everything I'm about to say does not represent the views of the federal government, SAMHSA, NIDLR, or any of the others. So just a little bit about Live and Learn, which Michael mentioned. So Live and Learn is a peer-run research organization. We work to improve autonomy, self-sufficiency, and citizenship for people who face mental health-related challenges around community participation. Our approach centers lived experience in the research and development process from start to finish to ensure meaningful engagement. And you can learn more about Live and Learn on our website, livelearninc.net. So today I'm going to talk to you about the Certified Peer Specialist Career Outcomes Study. I'll share some analyses and results from 2020 to 2022 and make some suggestions for research and policy. So I'm sure most of you here are already familiar with what a certified peer specialist or a CPS is. But just as a refresher, peer specialists are direct service mental health workers with lived experience with a mental health and or substance use condition who work with other people with similar conditions in a wide range of non-clinical activities. Like social work, professionalized peer support grew out of a grassroots movement of people filling in to help each other where the state did not provide. So the first peer specialist credential was created, I believe, in New York in the early 1990s. And since then, we've seen a real growth of the workforce and also increasing professionalization. So almost all of the states at this point, even California, have a peer specialist certification program, and many of those are Medicaid reimbursable. I think in terms of this study, it's important to understand that certifications are credentials that demonstrate a level of skill or knowledge needed to perform a specific type of job through an examination process. So CPS may use this credential as a stepping stone to other career goals, including in the field of behavioral health, or as we know, they might continue to work as peer supporters. But we don't know how many of those individuals use the credential to obtain other positions or in fact don't work at all after they get certified. So that's part of what this study was designed to address. So in that sense, we took a labor force participation perspective. So we recruited recently certified individuals to understand the impact of the credential once they got it on their employment trajectories. So this was a 3-year study from 2020 to 2022. You can see on the map here on the right, the states that we worked with: Pennsylvania in the Northeast, North Carolina in the Southeast, Texas representing the middle of the country, and Oregon on the West Coast. So partly we chose these states based on geographic diversity and partly on their willingness to share the contact information of people who had been certified, or having, in the case of Oregon, they have a public database there. And then also we were estimating based on the number of people certified in 2019, assuming that this number of people certified in 2020 would be similar, if not larger, although as we all know, 2020 went very differently than any of us had planned. So we, again, we're recruiting people from the point of certification. So we were looking to see whether they had ended up working in peer support or working on another field so we could compare those experiences. So we did a survey each year, 2020, 2021, and 2022, of the people who enrolled in our study. And we also conducted in-depth interviews with a subsample of 25, and I'll be presenting some of those data. So I wanted to just kind of start with some of the limitations of the analysis that I'm going to be presenting so that you have that in mind as you're seeing the results and can kind of wrap your head around sort of the meaning of these in the context of studies design. So it was not a nationally representative sample and it wasn't randomly selected. Recruitment started, we got IRB approval like the day before California shut down for the pandemic. So we don't know exactly how that might have affected our recruitment. Similarly, the labor market was in major flux, as everybody knows, over the past couple of years. So that might complicate our interpretation of the findings here. From 2020 to 2022, we did lose 17% of the sample to follow-up, and we found that there was a significant difference in those who were lost to follow-up versus people who stayed in the study based on their age, but it was the mean difference was only a couple years, and we didn't find any other differences. So in that sense, we were successful in keeping in touch with everyone. And the results, a lot of the results that I'm presenting today are preliminary. We're in the process of doing the longitudinal analyses, but you can find published analyses of baseline data on the project website at peerspecialist.net. So I'm going to present some of the data from the study and then kind of give you our current working model in terms of understanding and telling a story about that, and then show you those data, and hope that this all ends up being helpful and clear in terms of our conclusions. So we had a really good distribution of age, ranging from 21 to 83 with a mean of 46. Most of the sample was female, which you see a lot in mental health studies. 30% were male, and then we had a smaller sample, about 3 to 4%, who identified as non-binary, genderqueer, or transgendered. In terms of race, About 2/3 of the sample were white, and another quarter identified as Black. We had 5% as another race, 5% as American Indian, and then smaller, less than 2% who identified as Asian, Native Hawaiian, or Alaska Native, and 9% of the sample identified as Latinx. These are the education breakdown. So 15% had at least a high school diploma or GED. 39% had some college education. 15% had an associate's degree. 22% a bachelor's degree, and 9% had graduate professional school education. So this is not representative of the larger population of people who have faced serious mental health challenges. And part of the reason is because, as you all know, I'm sure a lot of the states restrict who can become certified as a peer specialist. So you have to have at least a high school diploma. And there's some other kind of biases in the sampling inherent in the certification process. So like some states restrict people who have been incarcerated previously from becoming certified, and there are other restrictions. Live and Learn is actually working right now with the SAMHSA-funded Doors to Wellbeing TA Center to update all of the certification requirements in the states. So if you receive an email from my team regarding the Doors to Wellbeing database, please do respond so that we can keep those certification requirements up to date, both for people who are looking to get certified in the states and also for, sort of contextualizing research findings and policy analysis. Here are some other characteristics that I'm going to mention in the analyses, so I thought you might want to see them. So again, this is sort of, not representative, right? So 96% of our sample had worked at least some in the past 5 years. So we know from other research that people with psychiatric disability or psychiatric histories have one of the highest unemployment rates of any disability group. So this sample is kind of different in that way. And 41% of them actually worked continuously over the past 5 years. 56% had used outpatient mental health services in the last year. 8% said that they never disclosed their mental health history to their coworkers. 16% were currently receiving Social Security disability insurance income, and 4% were receiving SSI. We asked them to self-report their diagnoses. 40% had a depressive disorder diagnosis, 25% a bipolar disorder diagnosis, 9% schizophrenia, and 26% other, and then 31% had a co-occurring substance use diagnosis. So on each of these header slides, I have a link to the papers that have been published with the baseline data if you want to look into those. And again, they're posted on our website. I will say that I am presenting here kind of a high level policy view of the results. There are more details about individual participant characteristics and how those relate to some of our outcomes in the papers if you're interested in that. But since we're in a limited time here, I've tried to kind of focus more and not reporting those. So we enrolled 591 certified individuals at baseline in 2020. We found that 55% of them were working in peer support. Another 21% were working in other jobs, and 24% were not working at all at that time. People who disclosed to their colleagues had a depression diagnosis versus another diagnosis and lived in an area with a lower local unemployment rate were more likely to be working in peer support compared to these other categories. People who were SSDI or SSI beneficiaries, veterans, people who had used mental health services, and those who didn't disclose at work were more likely to not be working at all. So in terms of the people working in other jobs, a third of those jobs were in community and social services jobs. So they were in the same labor category that peer support would be in if there was a labor category for peer support. But then another 2/3 were in a range of other occupational categories. I'm going to share now some of the experiences that they told us about in qualitative interviews to give a context to some of the survey data that I'll be presenting. So once they were employed, participants described workplace challenges that impacted their employment experience. And these fell into two categories. One, the presence of absence of support from organizational leadership, and two, variability in collegial relationships with their coworkers and supervisors. I'm just going to, there we go. Participants reported using a CPS credential both within and outside peer support roles, including work activities of non-peer support jobs and in their personal lives. So we did find, as we thought we would, that some people were using the credential as a career step. So some of them plan to pursue clinical degrees after the certification. For instance, one person said, I'm taking some online classes to get my associates in psychology and social work so that I can potentially go on to advanced degrees for those things. One person was working as a 911 dispatcher, and they said, there's hysterical and aggravated callers all the time, and being able to bring people down from a panic to functioning and calm is a good skill to have anywhere. For those who were seeking peer support employment, but were unemployed at baseline, they described challenges finding employment in peer support, mostly due to lack of available positions and in some cases, their own poor health. One person said that she had to apply for every opening every year for 3 years in her county before being hired. People described having to persevere in their job search to acquire a peer support role, and the implication being that their personal circumstances, so their own perseverance or personal networks or whatever, allowed them to do so. We asked people about leaving the field and job separations. One person said, I'm going to be honest with you. I think I was just so distraught and turned off with what had happened at my job that I just wanted to be done with peer support altogether. Another person said, I was experiencing burnout with the staff that I was working with. Also, I actually ended up going on disability because I just didn't do well there. So now we're going to look at the quantitative data and employment and peer support over the study period. So in 2020, 76% of the sample was employed in any job. And we saw that remained basically constant. So the same number of people were unemployed during the study period. Then when we look at that same sample of 591 individuals, we see it dips down in 2022, where only 48% of the whole sample was using their credential to work in peer support. But then here we see that we have a sort of a constant number between 2020 and 2021 of people, of the percent of the employed people who are working, choosing to work in peer support. And then we saw a significant drop here, where people stopped working in peer support and were working in other jobs. So another way to look at this, depending on how you like to look at data, everyone has sort of their own preferences. You can see this significant drop here in people working in another field versus working in peer support. So we also found that job tenure, so how long somebody is in a job, so job tenure of more than 1 year increased for peer jobs and decreased for other jobs over the study period. So you can see here we have in 2021, 82% of the people in peer support jobs have been there for more than a year and 59% in the other jobs. So those other jobs are newer jobs. And then we saw a significant change here in 2022, where again, 82% of the people who are working in peer support have been there for more than 1 year, and 47% of the other jobs are new jobs. So what we're seeing is people, some people are staying in their peer support jobs a longer time, but people are increasingly acquiring new jobs in other fields. This is sort of another way to look at it. So this number here is the number of years, average number of years that people have been in these different positions. So you see here in 2022 that the peer support jobs have lasted on average 4 years, and then we have these new jobs lasting less than 2 years in 2022. So when we asked people about leaving the field of peer support, or when it came up in interviews, one person said, I was so stressed out from the job and I was so beat down and I was so exhausted that it ended up leading me to hospitalization. And so I chose not to go back to the job, and I'm going to be moving forward from here. I'm not quite sure what I'm going to be doing next, but I know I won't be taking a CPS role. So this is sort of concerning when we're, training and certifying a lot of people in the States, and then they're not able to stay in the field. So we know that employment rates didn't change overall over time, but we did see the prevalence of peer support employment decline significantly between 2020 and 2022. And we saw that this job tenure in peer support increased and declined in non-peer jobs. So since the overall employment rate didn't decline and job tenure was longer in peer support jobs than other jobs, we saw that in the employment rates. I'm now going to put that in the context, so we want to understand why that's happening as best we can. So I'm going to put that in the context of provider shortages, where we also saw significant changes over time with the association, with living in a shortage area and working in peer support. I'm going to show some of the data on workplace experiences, particularly the data on burnout that we have in peer support jobs versus other jobs. We'll look at wages and financial well-being data, and then some of the other employment opportunities that participants might be pursuing. So we just last week had a paper on the baseline data published on provider shortages, which you can find there or on our website. So a mental health professional shortage area is designated by the Health Resources and Services Administration based on the ratio of mental health providers, psychiatrists, clinical psychologists, et cetera, to residents in specific counties. So these tend to be rural areas where there aren't enough providers, and there's sort of standards set by HRSA on how many providers you need per population to serve that population. So we know that certified peer specialists enhance the behavioral workforce, and they may in some ways be able to address the service provider shortage area. So we see this in other fields like dental assistants providing dental care where there's not enough dentists. So certified peer specialists can sort of fill some of those gaps, because as we all know, that overall they provide very effective services, and all these services are not needed to be provided by these clinical categories. So we had participants from 166 unique counties in our sample. 47 of those counties were characterized as mental health professional shortage areas. So 14% of our participants were living in shortage areas. This is lower than what you would expect, I think partially because the training and certification opportunities are often in urban areas. And so there isn't a lot of flow from those areas to rural areas where people might be taking peer support jobs. So you have a concentration of people in urban areas who are certified. So in 2020, we found that residing in a shortage area was not a predictor of employment versus unemployment. So you're just as likely to be employed in any job, regardless of where you lived. But we did find that it was associated with greater likelihood of employment in peer support versus another field. So you can see here, that's equivalent, any job. So we see a significant difference here where people are more likely to be working in peer support if they live in a shortage area in 2020. But we did see a significant decline in the likelihood of employment in peer support versus another field in a shortage area. So you can see here the blue bars are the people in shortage areas. So we see this basically evens out in 2022, where you have an equivalent likelihood of working in peer support. So this sort of effect of, you could think about somebody living in an area where there's provider shortages. Well, there might be more opportunities to work in peer support, or more of a need for you to work in peer support because there aren't those other providers to provide services. But then that opportunity sort of disappears more recently. So we did find the strong relationship of living in a shortage area and a greater likelihood of working in peer support, but that diminished over time to non-significant. So now on to workplace experiences and burnout, and we have a paper here of the baseline data that you can check out. Again, there's some individual characteristics such as age, race, I think veteran status that are associated with burnout that we report in that paper, but I'm not going to talk about here. So in terms of workplace benefits, participants in peer support jobs reported significantly higher job satisfaction than those in non-peer jobs across all study years. We also see that they are more likely to get benefits such as paid time off and health insurance at their jobs, and significantly less likely to work someplace where they're not offered any benefits at all. So these are, we would look at this data and say these are pretty high quality jobs. When we asked people about their experiences in peer support, they were generally positive, especially at baseline. People described the work as fulfilling. One person said, "I love my job and love my people." People were passionate about their work. They did report at times feeling intimidated by the work. So one person said that they were working hard to be on par with the clinical team. Another said, "It's a huge responsibility and I don't want to mess it up." So burnout has become an increasingly hot topic, especially in healthcare. The CDC just launched an initiative to address burnout among healthcare workers. So according to the World Health Organization, burnout is feelings of energy depletion or exhaustion, feelings of cynicism related to one's job, and reduced professional efficacy stemming from chronic workplace stress. So you can think of this as burnout is when exhaustion and cynicism are high and professional efficacy is low. And we use the Maslach burnout inventory to study this. So the Maslach team also created an areas of work life survey, which was created to assess employee perceptions of qualities of their work setting that play a role in whether they experience work engagement or burnout. So the survey includes measures of workload, control, reward, community, fairness, and values at work. So we saw significant differences in baseline burnout between peer support and other jobs. So the peer support jobs they actually had, you can see the blue bars, much lower on, significantly lower on exhaustion and cynicism and higher on professional efficacy in 2020. We also saw differences in some of the domains of the areas of work life. So community and values, they were much better off in peer support jobs than in other jobs. When we did our multivariate models, which are reported in that paper, we found that, sorry, this is actually in reverse, but lower burnout was associated with having fewer negative experiences at work, better ratings on workload, control, reward, and community, as well as fairness and values, and also that people who were working in a peer support job were more likely to be less burned out. But we did find that peer support workers who had higher burnout were more likely to be looking for a new job, especially those with high cynicism. So you think about, high cynicism being like, this isn't doing any good to help people, feeling really that negativity about your job. Those people are the ones that we saw that reported that they would be looking for a new job and potentially leaving the field. So burnout and workplace challenges in peer support jobs were particularly, people talked about the administrative burden. But people also talked about their workload, like some of the downsides is being the only peer and having so much responsibility. One person said there's so many different clients and not having enough space to put them all. So I'm having to really add more and more to my schedule, which really leaves no time for me to do my documentation. Another person said, I'm still trying to find my way with it to even as far as the paperwork, doing the progress reports and how they want it done, what to include, what not to include. I'm like, well, I can't write clinical notes. So you can kind of feel through these quotes, how overwhelmed these people are feeling in their jobs, particularly with paperwork. So burnout increased significantly over time for everyone. But we found that people in peer support had significantly lower exhaustion, cynicism, and greater professional efficacy, even though we did see increases in burnout over time among those. They're still lower. So on to wages and financial well-being. You can find this paper here. So these are compensation numbers for 2020. We pulled data from the Bureau of Labor Statistics and looked at other occupations.
Excuse me, Mike.
What about him?
Sorry, I heard something wrong. So all occupations across the US, the average wage in 2020 was $27.07. Community and social services, again, these are jobs that are sort of in the same domain as peer support, on average had a wage of $25. Community health workers received a wage of $22. And social human service assistants, who are the lowest paid occupational category in this domain of community and social services, received on average $18 an hour. And then the data from our sample found that peer support, people working in peer support were receiving $15.93 an hour on average. One person said, unfortunately, CPS are not compensated at a rate that is sustainable. Another said, I'm not going to lie, massage therapists make really good money. I can make more on a Sunday than a peer can make in a whole week. I made $60,000 yearly managing apartments with 0 certification requirements compared to $28,000 to help support my local community as a mental health peer specialist. So, and we found over time that the increase in wages for peer support jobs was significantly lower than other job types. So we did see an increase for both of these, peer support and other jobs, since 2020. You can see the lines here. So the blue line is peer support. You can see these are both going up. but actually the other jobs are going up at a higher rate. So I put this in a table for you. So you can see that 1593 here, 2020, actually the other jobs were making an average of $15.60 in 2020, which is a difference of 33 cents an hour. And then you see that sort of flip here where other jobs got a big bump in 2021. And this number down here, this is the standard deviation. So this, is a range that could range on either side of that. So some of these people are making almost $9 more than this average. So then we see that the peer support jobs are making on average $1.41 less an hour. And that works out over the whole study period. Again, this was less here to $1.19 an hour, which doesn't seem necessarily like much, but then if you work that out to a full-time job is 2,080 hours a year. So that's where I'm working in peer support versus another job. You could potentially be leaving about $2,500 a year on the table, which is about $200 a month, which is groceries for a lot of people. So there wasn't a significant difference in the actual wages, but the increase was less for peer support jobs between 2020 and 2022 compared to other jobs. I'm going to leave that for a second. So we asked about financial well-being as well as wages. So the Consumer Financial Protection Bureau defines financial well-being as a state where a person can fully meet current and ongoing financial obligations, can feel secure in their financial future, and is able to make choices that allow them to enjoy life. So you can look up the questionnaire. It's obviously freely available on the internet because it's made by the government, but it asks can you buy a gift? Can you come up with money for an emergency? Things like that sort of determine your financial well-being. So the CFPB did a nationwide study and they found a median score of 54, and that included people who were employed, people who were not employed, people who were retired and disabled. So that's really the most broad sample that you could think of for a survey like this. So their median was 54. Our sample in 2020 had a median score of 52, which is described as a moderate likelihood of struggling to make ends meet and of experiencing material hardship. So then we looked at this change over time. Again, the blue is the peer support jobs. You can see actually they were a little bit higher here in 2021 and then took a big dip here. So financial well-being actually declined among all participants despite an increase in wages. And I'm sure you, like me, can see this in your own life, right? Your wages have gone up maybe a little bit, but your groceries have gone up a lot. And if you're in California, your gas is $6 a gallon. So we did find that wages were associated and working full-time were associated with having greater financial well-being. But again, that measure asks sort of about a broader range of experiences than just the wages that you receive. So we saw that peer support jobs, the trend was non-significantly towards lower financial well-being compared to other jobs over time. But, we have to think about, the study only got until 2020, but life continues for a lot of us into 2023, 2024, and maybe into 2025 if we're lucky. And so what are those trends going to look like if we had data from those years? So one person said, I thought this was a really great example. This person's in a job interview for a peer support job. They said, I kind of need like $18 an hour to justify this position. And the interviewer said, well, if you want the mid-range to the high range of this pay position, then it's not for you. And I said, why do I have this certification? Why do I have all this training and this background if you're going to always expect me to start at $14 an hour? So hourly wages for all types increased over time, but the increase in wages for peer support jobs was significantly less than for other jobs. And, a volatile economy, cessation of pandemic stimulus payments, a lot of those factors may have contributed to significant declines in financial well-being for everyone. So we asked our participants about self-employment and found that almost 20% of them had turned to starting a business to improve their income and freedom at work. They had all types of businesses. Some had peer support businesses. Some were doing writing, janitorial work, gig economy, hairstyling, landscaping. And when we asked them why they had chosen self-employment, income really and financial self-sufficiency came out at the top, but they also talked a lot about freedom and control of their schedule and their work, and as well as contributing and innovation to the field. So, I think of sort of these peer specialist businesses as sort of an example of career ladder discrimination, which we see in other ways from other studies, and I'm not reporting that data here, but that people work in a position, maybe they're the only peer position, or maybe there is no position beyond that. I was actually just talking to somebody who has been managing a peer support program for almost 15 years, and there's nowhere to go, even though there's a whole agency above them. There's no management position for them to move into, and so they're thinking of leaving the field. I'm really interested in the idea of peer specialist-owned independent practices, which could both expand service options and address the service provider gap, and also provide opportunities for the peer specialists. So a 2020 survey by Wallace Adams found that 68% of peer specialists reported new use of technology, which allowed them to provide services outside of the agency settings. So I think that's really promising. But we still see policy, practice, and attitudinal barriers that prevent peer specialists from exercising their competence and credential in peer support. So other licensed healthcare providers, obviously, doctors, therapists, start their own businesses. But peer specialists, really, there isn't not very many opportunities to do that. I know there's some stuff going on in Montana and other places here and there, but not having those licensing and business opportunities is one example of way that. Okay, so I know we're sort of running out of time here. Very quickly, because we went over this already. So we saw these employment rates changing, where peer support employment declined significantly over the study period, and that new jobs tended to be outside of peer support work. This shortage area likelihood of working in peer support diminished in 2022. We saw that the increase in wages for peer support jobs was less than for other jobs. And that burnout was increasing over time, even though it was still less than in other non-peer jobs. So given that the overall employment rate didn't decline and new jobs tended to be outside of peer support, we think that CPS were taking on new non-peer work, even when they're living in shortage areas or areas where there's low unemployment. They're seeing better wage growth in other fields. They're experiencing increasing burnout as time passes in certification. They are recognizing that you need to have a lot of particular personal circumstances that factor into acquiring work in peer support. And so I think we're kind of seeing a story of why we might see long-term exit from the field of peer support, even for people who have gotten certified. So, I think we can, all of us here probably agree that CPS must be seen as an asset to the workplace, or they will leave for other jobs. One important initiative that we can undertake is matching employers with individuals pursuing certification. So during the training and certification process, really helping people see where they can get jobs, connecting them with employers who are hiring. We need labor force policies that elevate opportunities in shortage areas and stimulate acceptance of peer support in the service array. So that might be, increasing remote access to online training, which obviously we've seen a lot of since 2020. But also providing financial incentives for relocation to rural areas, like we see with doctors, for instance, can get some amount of loan forgiveness as they go work in a rural area, but we don't see those kind of incentives for peer specialists. We need wage equity with other essential healthcare workers. I think the national certification process, and I know there's a lot of debates about professionalization, and I feel both sides of that inside of me, but I think that can also lead to like collective bargaining, like we see in other fields, if we have that national certification, where people can bargain for better wages. Obviously, we need organizational interventions that address work-life elements, some of those that I talked about, that help prevent burnout and reduce turnover, and perhaps supporting innovative practice models that allow flexibility and fair remuneration alongside other practitioner types. And of course, ongoing research on employment and job quality, including a Department of Labor occupational category, which would make projects like this much more efficient and much easier, and also doing employment tracking by the states, so that we can keep an eye on these numbers and these different trends that are going on. So I just want to thank NIDLR again, my research team, Judith Cook, Mark Salzer, Jane Burke-Miller, Morgan Pilat, as well as our advisory group, Lene Brown, Lauren Jessel, Leigh Harris, Marva Weigelt, and Lala Dews to help design the survey. And then I will stop there for questions if we hopefully have time.
Thanks, Dr. Ostrow. And so we do have a team that has collected questions. Lupe and Grace, are you guys prepared to start the questions?
Oh, we are. There were questions, so we might only have time for a few here. Someone wrote in the Q&A, the question reads, how has the work done by peer support since you entered the field? Which impediments have been the most difficult to overcome by peer supporters?
Well, I think, based on this data, right, one of the impediments is wages. Being able to, we talk about recovery, right, as not just sort of clinical measures or not even clinical measures, right, but like having a home, a family, a job, a place in your community. Well, unfortunately, the system that we're living in, you have to have adequate finances to do that. So I think that's definitely one of the barriers, is not being paid a living wage. And I think also, we didn't, like I said, we had lower burnout than other jobs, but still increasing. And so there's a lot of other research that's been done on the organizational environments that people work in. And you see a lot of things in those results about like providers not understanding the peer role, right? That's something we've been talking about for a long time. I think if you look over time, right, with the evolution of the peer support role from sort of a grassroots, informal way of providing support to one another to this increasingly professionalized role, all the work can't be on the peer specialist to make that transition, right? It can't just be, well, now we're giving you a certification and a wage and you go work in this place. Like the whole system has to change around them, and accept people into the workplace, because how can you be happy at work when no one understands what you're doing? You're not getting paid very well, and you don't even feel like people want you there, when in fact you're doing really good work, as we can see from the research in helping people.
Thank you. The next question reads, how did the role of peer support change during COVID, assuming they could not provide support in person during much of 2020 and 2021? How did they manage providing support, and were they supported?
Yeah, I mean, we saw a lot of this in our qualitative research where, peer support workers in many cases were deemed to be essential workers, so they could go to work. So, I mean, some services were being provided online, and that study that I cited, showed that people were increasingly learning how to use technology such as Zoom to provide support. But also, we heard participants talk about the experience of being one of those essential workers that still was required to go to work, and having a lot of pride around that role and supporting their communities during the pandemic.
The next question here reads, I find that there is a broad lack of support and intentional integration of peer providers within clinical teams and agencies. I believe that this is a big factor in peer providers getting bummed out. It may not be the work, but the lack of intentional support, supervision, and education of non-peer staff, making the workplace too stressful. Any information about this in the study?
Yeah, I mean, I think those experience that this person is talking about, is we see that reflected in the outcomes data, right? That those things really, that you can talk about having these difficult experiences, work where you don't feel supported or accepted, but we're actually seeing the outcomes of that. Like, it's not just, oh, people are feeling bummed out at work, but they're still going to work and doing good work. Like, they're leaving for other jobs.
Okay, next question reads, is this data from mental health peer support only, or does it include substance abuse peer support?
So actually, there's a good report from the SAMHSA-funded Peer Recovery Center of Excellence from earlier this year, that actually most of the states, or at least 30 something of the states, their certification doesn't really make a distinction between mental health and substance use, which I think is great, because we've had this artificial distinction for a long time between the two systems that isn't serving anybody. And so I think peer support is one way of bringing those together. If you remember the beginning of my slides with the sample demographics, the study was designed for mental health peer specialists, but 30%, a little more than 30% of our sample also had a co-occurring substance use diagnosis.
Thank you. Next question reads, was there any data on peer support with English as their second language or the demand for peer support that can speak other languages?
Yeah, our study sample only included people who could speak and write English. So I don't have data on that.
Okay,
But great question and great research area.
all right. Next question. Would you attribute the longevity in the peer position to the need or experience in those positions?
You said then it cut out a little bit. The need or the experience, you said?
Or overall positive experience in those positions?
Yeah, I think some people, I mean, I think there's a wide variability where some people really, we saw some of what people said that they really do have a positive experience in their jobs, for whatever reason. And but this it just varies. Like I think it varies by agency, by person, again, like if it's your personal circumstances that have allowed you to get one of those jobs, you might have a better experience than somebody who had to spend 3 years fighting your way in. And there's just, all over the country, right? There's different availability of jobs, different nature of jobs for working in a peer program versus another program, which I didn't show here.
Okay. Will a similar study be conducted with more variant ethics, all states included?
Yeah, if you give a couple million dollars to do this study, it's a lot of work. Yeah, I think to design a study like that, you would need significant resource investment to recruit from all of the states. So just getting the people from 4 states was a lot. Although again, we were doing it in March of 2020, but yeah, I mean, you could definitely design a study that way. And I think, we made an agreement with the states that we worked with that we wouldn't report results by state. But I think you could also, since every state really is different, you could do a really nice study that way, but it would be a lot of work.
Okay. What kind of research do you think would help advocate for greater investment by states in peer support?
So, I mean, we have seen a greater investment by the states in peer support. And I think that, a lot of that has been built on the results that we see for the effectiveness of peer support in helping service users. And so we have a fairly well-established evidence base for the effectiveness of peer support, for the outcomes that it delivers for service users and service systems. And now I think it's about sort of recognizing the value of that workforce, and what they need, given that they're still sort of in a disparity position, despite being a provider category. But we also, are seeing like research on other healthcare practitioners who are suffering in their workplaces as well. I mean, nurses had a terrible time during the pandemic. We're still seeing a lot of those shortages play out. So I think we need to think about, nurses are essential, doctors are essential. If we decide that peer support workers are essential workers, like we also have to invest in them, and recognizing that like a lot of those people, I mean, by definition, right, they're coming with a disadvantaged, marginalized background. That's why they're in the job. So, I mean, you also see that obviously with other healthcare practitioner types too, but sort of not categorically in the way that we do with peer support specialists. And so thinking about how we can treat those people as valuable, which they are.
Okay, I think we might have room for one more question before Michael closes it out. So this question reads, were your participants on SSDI working full-time or part-time, have a goal to get off SSDI? Did receiving SSDI have an impact on the overall well-being or working experience?
So we did find some associations with being on SSI or SSDI. We didn't ask them whether they wanted to be working full time, and I can't recall all of those data off the top of my head, but if you look at the baseline papers, you can see the findings that we found related to burnout and financial well-being and employment status.
Michael, do we have time for another question or?
Yes, do one more.
Okay. This last one reads, was there any data collected about average active caseload numbers as well? Peers typically worked with 10 individuals or 20 individuals at a time.
No, we did not ask them about their caseloads, I don't think. But a good question.
You can ask another.
Okay, let me find another question here. In your opinion, from the data in the study, how do we move forward on macro scale changes to move peer support workforce in a positive direction?
So I am, I think mostly in favor of the national certification standards that can make a more unified workforce. I think that will, right now, it's so all over the place that you can really only organize with other peer supporters in your state to advocate for better working conditions. And I think if there was sort of a national, like a union, of peer supporters, that they would have a lot more power to organize for better working conditions and better pay. And again, like I said, I'm interested in this idea of peer specialists being able to start their own private practices for a number of reasons. And so I think the national certification standards can help with that as well. Like the peer support community has to decide what it is they want out of the workplace. And how do we do that when everyone is really fragmented? And there aren't really unified standards.
Well, thank you, Dr. Ostrow. I am looking at the chat and the questions. You still have 100 questions left. But certainly the chat is expressing the excitement and the great conversation that you have presented. I personally want to thank you on behalf of SAMHSA and those that participated. Once again, some of the personal questions is the PowerPoint available? And I'm just going to encourage everyone to, if you can, copy the chat box, because there's a lot of information and resources placed in the box for your taking. A certificate of attendance, if you email me, I can send that to you at this point. But certainly the PowerPoint can be available. How do we get that to them, Dr. Ostrow?
We will post it and as well as the recording on the website peerspecialist.net.
Everyone got that? Peerspecialist.net. Okay.
It'll be on the homepage.
Peerspecialist.net. And any last thoughts, Dr. Ostrow, before you close out?
Just thank you for having me and for everybody for listening and learning. And yeah, feel free to reach out to me with any questions. Yeah, we're here for you.
Thank you. I just want to thank Dr. Ostrow, Ms. Donna Dimitrovic, our IT team, that is Group Guadalupe Mendez and Ms. Grace Lee, and those that participated in today's webinar. Just let's continue to promote hope and understanding and work to create safe places and environments where people in recovery can continue their recovery journey. And remember, when you put hope in the mix, anything's possible. That recovery is real and hope is real. Thank you very much for attending the webinar. God bless you.
Thank you.